All right, welcome to the October ED provider meeting. I always like to try to include some clinical stuff in these meetings as opposed to just logistical updates. So one of the big things we're going to be talking about today is the brain injury guidelines. There's a few other things that are coming up that are important also, like our Tenecteplase conversion. Let's go ahead and roll into a reflection. This is something I pulled out of Stephen Covey's 7 Habits of Highly Effective People, something I read long ago, but this is a small excerpt from this in the habit number 5, which is seek first to understand, then to be understood. Communication is the most important skill in life. We spend most of our waking hours communicating, but consider this. You have spent years learning how to read and write, years learning how to speak, but what about listening? What about training or education have you had that enables you to listen so that you really deeply understand another human being from that individual's frame of reference? Comparatively, few people have had any training in listening at all. I think as physicians, we have had some training in listening, but thought that was a good habit for the reflection. You're going to have a lot of this stuff in the minutes, so I don't want to belabor this, but these are the most recent volume metrics with the blue and the left without being seen at the bottom. This is a list of our monthly average census. So you can see for the last several months, 162, 163, 164, 166, 167, just barely creeping up about a patient or two per month for the last several months. This was taken the last day of September, so the MTD or month to date is September. We were at about 4%, still a little bit higher than where we would like to be. Throughput numbers slightly higher than August, with the exception of our admit to transport time, admit to bedside time, actually. And this is really stuff that's really more hospital based, out of our control, but they have made some significant improvements there. So that's great. Down to 126 minutes from admit order being placed to transport time from 139 the month before. The rest of the numbers are pretty stable in terms of the arrival to discharge, up just 9 minutes from the previous month before. Slight creep up in the arrival to provider time, 22 minutes. And that's it for the metrics. So some of you have been talking to trauma about your head injury patients specifically, and more recently, you've been hearing from trauma about the brain injury guidelines. This is actually something that came out in 2014 to classification of brain injuries, specifically intracranial hemorrhages, and a proposed algorithm for how to manage those. But this has gotten a lot more press because a validation study was just released in spring of 2022. So the residents through Spectrum are all talking about this, and they basically want to be applying these brain injury guidelines to how we manage our head injury patients. So I want to talk about this, make this big guideline proposal. I've talked to the trauma team about this extensively through our trauma operations and trauma peer review committees, and they want to implement this. I requested that we kind of hold until it's presented to the group today, but this also gives us an opportunity to kind of go back and provide feedback on this. So let's start by first just going over the 3 classifications. They're listed here, and the classification is the worst of any of these. So if you have a displaced skull fracture, but no intracranial bleed, nothing else, you're a big 3, just with that, for instance. If you have more than one area of subarachnoid hemorrhage or scattered, that's a big 3, no matter how big or small it is. So it's the worst of any of these. The subarachnoid hemorrhage, there's been some question as to what these terms mean. Trace, is that small? Is it trace? That I think is something that's up for further discussion. And we're going to talk about the implications of this momentarily, but let's also move on now to what the recommendations for treatment of each of these categories is. And I'll mention that aspirin is considered a antiplatelet agent. So anyone who has aspirin on board would be a big 3, but that leaves some question as to, well, what is their brain injury? Because we don't admit everyone that is just on aspirin if they don't have any other factors. So it's not, there are some gray zones with this. So recommended management for big 1, and by the way, this was like a 2,200 patient study that basically showed that if you do this, there's no harm, or no one needs intervention and such. So all of these patients get a trauma consult. The big 1 patients only need 6 hours of observation, during which time they're receiving Q2-hour neuroassessments, reassessment prior to discharge, GCS at their baseline, and then they can go home. They don't need a repeat CT scan, and they don't need a neurosurgical consult. And this is the one that would, potentially represent the biggest change in practice for us. So the big 2, trauma consult, these are admitted under observation status for 24 hours. The recommendations, again, are no repeat head CT scan, although that would be up to the trauma team, since that would be after admission. No neurosurgery consult required, but they certainly could consider one. Q2-hour neuroassessments, and then GCS at 15 or at baseline at discharge. And then big 3 is basically just our standard current treatment: admit to trauma, repeat head CT scan per trauma, Q2 neuroassessments. And then obviously, if there's more significant complications, concerns with brain injury, our regular standard of care, which might include anti-epileptics, or even, things like mannitol, that kind of stuff. So we looked at what the implications of this would be, specifically with what's our volume, and specifically those big 1 patients. How many would this be? Between April and June, so a 3-month period of time, we looked at 44 patients here at our institution that were admitted with TBI. 11 of them were only concussions. 27 met big 2 or 3 criteria. So there was really only 5 that would potentially have been candidates for observation in the emergency department prior to discharge. And 3 of those, or maybe 3.5 of those, would have required admission anyway, because they had either multiple trauma or other comorbid medical conditions. One of those was in the emergency department for 9.5 hours anyway with their workup. So that wouldn't have really prolonged their stay. And then the other probably would have qualified. It was listed as a subtle rather than trace subarachnoid hemorrhage, but that one probably would have qualified. So maybe 1 patient would have qualified. So it's not huge numbers, but there still are some important considerations for this. First of all, for the observation period that's recommended of either 6 or 24 hours, that, for clarification, begins when they arrive in the emergency department, not when the injury occurred. So that it's still a little bit of a gray zone if they come in and their injury was 2 days ago. These are things that would need to be kind of discussed and collaborated with, because that's not easily defined if it's a subacute. But the big guidelines are defined by time of arrival. There's also a lot of other important considerations, which this is what we do best. When we see a patient with a hip fracture or, whatever, we're obligated to look at the entire patient, including their comorbid medical conditions, their social situation, their follow-up, their health literacy, and all of this goes into the decision as to whether we admit or discharge somebody, whether it be trauma or anything, whether it be a severe asthma exacerbation or whatever. So this is what we do best, and this is something that I had a conversation with the trauma team, because if you've got a patient, for instance, that is 85 years old, lives alone, uses a walker, is a high fall risk, and now has a 3 millimeter subdural hematoma, is that still the right patient to send home because they're big one? Just because they're big one doesn't mean that you have to send them home. It means you have a collaborative conversation with trauma, taking into consideration need for things like physical therapy assessment, OT assessment, discharge planning, all of that kind of stuff, all still should be factors for admission or not. All of these need to have a collaborative discussion with trauma if there is a recommendation to observe them in the emergency department. And just because they're big one does not mean that they don't need to be admitted to the hospital. And then another important consideration is, if we are to keep these in the emergency department, then we need to make sure that our nursing staff understands what we're doing and that we are ordering the appropriate nursing interventions. Just like with our hemorrhagic stroke patients, I would recommend that, if you discover that someone is a big one patient with a small intracranial hemorrhage, that you go to that emergency medicine hemorrhagic stroke order set and place those orders just like if it was a hemorrhagic stroke for the Q2-hour neuro checks. There's also some stuff in there like elevate head of bed 45 degrees, seizure precautions, those kinds of things. Don't forget to order the nursing interventions, because those are part of the observation criteria. With that being said, I think there are some opportunities. There's some literature that I have listed here. One of these articles is a much smaller article. It was only a couple hundred patients compared to a couple thousand patients, but they had I think a couple patients that had worsened and required intervention that had epidural hematomas. So that's something that I personally looked at and kind of wondered whether it was appropriate that epidural, so at that top line epidural of any size, not immediately jump to a big 3. But this is something that I'm interested in your feedback. I am not a big fan of keeping patients in the emergency department. As you know, it clogs the emergency department, reduces our throughput. We've worked hard to improve the throughput with our psych patients by bringing them into the hospital. But it is kind of hard to get away from the literature, and if these patients are really only going to be observed for 6 hours, it's hard to justify putting them into the hospital and dirtying a floor for only 2 or 3 hours, because they're going to be down here for 3 or 4 hours getting their work up anyway. So I'm interested in feedback on this. I know there's been some patients that have had some kind of negotiations with trauma on this already. Anyone have any thoughts or feedback so far?
I have a question, Snilda.
Yeah.
So let's say they do have, like the case the other day, a 2 millimeter bleed. I don't know that this guy was in the ER for 6 hours. He's already wanting to apply these rules. What do we tell them for restarting Coumadin? How many days do they hold it? Do we not need to hold it?
Well, if they were on Coumadin, then they should have immediately jumped to a big 3 and been admitted.
Well, yeah, he was on Coumadin, and they were annoyed that we even called, and we need to know these guidelines and blah, blah, blah.
Right.
They're lucky they didn't talk to me, because I would have punched him in the face. It would
But
not have been a nice chat.
You're absolutely right. If we're going to be applying these guidelines, we need to know them. We need to know them as well or better than the trauma team, so that we can, discuss them just like we know our chest pain algorithm, so that we're discussing that with the medicine team as to what is low, intermediate, high, what the heart score is. We have to know these, so that we can have this discussion. So you see down there at the bottom, anticoagulants are all big 3.
Oh, sorry, I'm on the phone, so I can't see it, but okay, so that automatically jumps him. Yeah, I mean, he didn't say anything about, keeping him for 6 hours, and he just was annoyed that we called.
I
think that we didn't know these guidelines.
I think it also is really important that when we get these patients, we read the entire CT scan, not just the impression, because, and we probably need to even look at these, because if there's an intraparenchymal hemorrhage, it matters if there's multiple locations. That makes a big difference, and that may not be in the summary. So we need to look at these closely.
Hey Dan, this is Ryan. I just wanted to. Oh, sorry. Go ahead.
I'm sorry. This person should have had a consult. Does that mean? Because we were at Southwest. So, what is a phone consult good enough?
No, if you have a bleed at Southwest, all of these are supposed to get a trauma consult. So those, this might be a scenario where you transfer to the emergency department.
Okay.
So that the trauma can actually see them, and then they might be observed in the emergency department for these big 1 patients, if it's Southwest.
Yeah, it was interesting that we hadn't even seen these guidelines. They want us to apply them, yet they weren't applying them correctly. So, I don't know.
I will have a cheat sheet out, but I do want to provide feedback to them after this meeting. Ryan, did you have comments also?
Yeah, I just wanted to know if we need to be talking to neurosurgery at all unless they're big 3, because I think that's also a driving piece of this, is that neurosurgery doesn't really want to be involved in discussion about these cases if they're not going to be operating right away. And if it's big 1 or 2, can we just field this through trauma? And if they feel it's necessary to involve neurosurgery on some of these higher risk cases, low or moderate risk cases, then they can do so after being seen. But I think from Southwest, just transferring downtown would be great, and then not having to field both phone calls on our shoulders. I don't know what you think about that, but it would be a nice change.
Yes, you're correct. There's a neurosurgery consult mandatory for big 3 patients. Big 2, you can leave it up to trauma to decide if they're going to call them or not. So, if you're following these guidelines, we don't really need to call them. And then big one, they really don't need neurosurgery. So it's just trauma. There is an article for modifying these, which I will send out after the meeting today. This was a much smaller study, but their recommended modification was to bump all epidural hematomas into big 3, regardless of size. And then they had it made it a little more complicated, but the subarachnoid hemorrhage was classified by like the size and the number of sulci and those kinds of things, since it's a little bit non-specific. What does localized mean? What does trace mean? So I'm going to provide that feedback to them. I don't know. I was always taught that, you know, the epidural hematomas are high risk for progression. So I was a little surprised to see the epidural as not requiring repeat imaging. But I can provide that feedback. I don't know if anyone else kind of is nervous about any of these. All right. Well, excellent. Let's I'll provide that feedback, but you know, I think we are going live with these, so there will be instances where if we have a big one patient, which is rare, we may be asked to observe them. And obviously, this would be someone that you would want to put into ED observation status like we do for our psych patients, to, you know, capture that appropriate level of care and billing that we're providing to those patients. Julie, I knew you were going to say that. All right. All right. I want to talk briefly about long-acting injectables because this is a little bit of a flip-flop. Back in, I believe it was April, there had been a case that had brought this up. We had asked for clarification, and the recommendations were at that time that we not provide long-acting injectable antipsychotic medications against the will of a patient, even if they're on a court order. So we give the long-acting injectables, things like Invega and stuff like that, for patients that have missed their appointments. They're not compliant, but are willing to get the injections. But we said no to you know, a patient that was floridly refusing the medication. We've checked with legal. We've checked actually with Judge Murkowski. And the revised recommendation is that if the patient is there on a court order for non-compliance, and that court order includes medications, it doesn't have to say long-acting, just medications. And if the patient is non-compliant with that, then we can provide the long-acting injection, even if they're saying, I don't want it. So this is a bit of a gray zone. Every single one of these cases is unique. So the recommendation is that we are legally allowed to do this. We are legally supporting the team to do this. And we know that many of these patients, providing this medication can, you know, can be the necessary step to prevent a psychiatric hospitalization. So it is certainly good and resource sensitive to provide that. However, there may also be situations where you just don't feel comfortable with it. Somebody comes in and says, hey, I'll take something else, but that medication, I had all these side effects. It, you know, it made me feel like this, that, and the other thing, and you don't know what else they've tried or what else they failed. You know, we're not 100% certain of what has been used in the outpatient setting. If you don't feel comfortable providing it because you feel that it is not medically appropriate based on what the patient is telling you, then you don't have to give it. And this is another important point. So patients will come in with these court orders for noncompliance, and our hands were a little bit tied before because we told you guys that you couldn't give them the long-acting injectable unless they wanted it voluntarily. But if they were non-compliant and they had a court order, there was really nothing we could do other than hospitalize them so that they could give them medicine in a psychiatric hospital. But many of these patients were not like actively suicidal or such, and so it just didn't necessarily always feel like the right thing to do. So legally, if they come in with that court order for noncompliance, you can negative cert them and send them home, or in this case, it would be back to case management. And then it's up to them to figure out how to hospitalize them if there's not an emergent psychiatric need that day. So, if they're upset that the patient is not taking their medicines, but the patient is not actively suicidal or homicidal, and it's otherwise someone that you wouldn't necessarily hospitalize, you can send them back. But I would do this, in close consultation with their case management agency, say, look, I don't feel like I can justify hospitalization. I'm going to give them a short acting med. I'm going to give them something, but you got to see them tomorrow or such. These are going to be rare instances, but I wanted you guys to be aware that there is legal precedence for this. You don't necessarily have to hospitalize someone if you don't feel that they need it, even with a non-compliance order, but this would need to be done in close partnership with social work. And typically these patients also have an outpatient case management that you'd want to coordinate with. Questions on this? None of these cases is straightforward. We all acknowledge that. Okay. Now, admission level. Wanted to talk briefly about this. We haven't talked about this, and I don't know if we've ever talked about this. So correct placement of the patient, including the admission order to the 3 categories, which is acute, step down, or critical care, is really important to improve our admit to transport throughput time, and also to ensure efficiency at the hospital so that when someone makes it to the floor, they don't need to be transferred to a different level of care. So I've gotten some feedback through the CRC that we're typically getting this order wrong between 1 and 5 times daily, which, we're really trying to improve that throughput, that door to transport time. And it's providing a lot of work for the admission placement team, the CRC, because they're trying to dig through the chart and they're trying to do checks and balances and make sure that the admission level that we're placing is appropriate. Now, they have this long list of guidelines that is really not our responsibility. It has to do with which floor is neuro and oncology and cardiac. And so it's not just what their acuity is, but what their diagnosis is. And so it's a little bit more complicated for them to just find a bed because there's these other factors. So they are going through the chart, but we need to make sure that we're getting this right. And so I've dumbed this down to some very, very basic guidelines to help us with that. Hopefully most people already know this, but I'll go over them briefly. And I might mention that just a couple weeks ago on September 20th, 9 out of the 33 admission orders that were placed with the wrong acuity order. So what's our general rule of thumb? So this is my rule of thumb, and I think hopefully other people do this, but basically, if someone needs any sort of intervention, including vital signs, every 2 hours, then it's step down. If they're on any sort of drip other than just heparin, so any sort of vasopressor drip, or cardizem drip, insulin drip, anything like that, then it's step down. The one that I think we oftentimes get correct is our gut, is someone going to get worse? it's a GI bleed, their hemoglobin's good, but they're, they're stooling every 2 hours. They're septic and they're old and they have a bunch of comorbid conditions and their vital signs are okay right now, but their chest x-ray looks horrible. We have that gut prediction as to if somebody is going to get worse and they're going to progress from a lower level of checking to a higher level of checking. Those are step down patients. And then if they're septic and that repeat lactic acid is still greater than 2, that's at least a step down. So what's GMB? Basically, if they don't need to be checked, including vital signs, more frequently than every 4 hours, then it's GMB. Their vital signs are normal-ish. They're stable. They don't need more than Q4-hour interventions. These are just general rules of thumb. And then, of course, critical care, we should be getting 100% of the time correct because we're actually talking to the critical care doctor and having them accepted to critical care. I'd remind people that BiPAP is going to critical care because we've gone back and forth on that a little bit. And then one last caveat is there are patients that we know are high acuity step down, like, that really bad respiratory patient that is going to medicine or family medicine, but we're concerned that they might progress and need critical care, or they might need a critical care consult. There's no order that you can specify that, but you are quite able to just pick up the phone and call 5454 and say, hey, I'm admitting this patient to step down, but if there's a bed on H2, put them there because they might need that acuity adaptable bed. Our H2 beds are acuity adaptable, so they can be critical care step down, and I believe they can even be GMB, although we try to move those off that floor. So that's just another consideration so that somebody doesn't need to physically transfer from a step down non-H2 bed to an H2 bed if you think that they're likely to progress to that level. So this brings us to the admission order. Why are we getting this wrong? I don't know, but I have a suspicion it's because we're more and more having residents or newer APPs place these orders. So the ask is to consider those general rules of thumb, to discuss the actual details of the admission order for anyone that's placing the order other than yourself, specifically our residents, and specifically discuss acute step down versus critical care. And then, as always, making sure that we're specifying the correct attending and admitting physician in those admission order parameters. Because I got a sneaking suspicion that some of these might be going in by residents. And also, don't forget that really the only service that places their own admission order is trauma, and those are trauma residents. So don't forget to take a peek at that order and discuss with the trauma team specifically, is this patient going to step down, critical care, GMB, so that we're collaborating on that and getting it right. Questions on this? Anyone else feel that those general rules of thumb are not necessarily what you've been using? I mean, I think a lot of us, it's kind of a gut feeling. We've been doing this for a long time, so we know. All right. Stroke, you've been receiving in my provider updates that TNK job aid. You'll get that again before our official go live date on October 12th. I just want to kind of hammer home to everyone that the STEMI dosing for TNK is different than the ischemic stroke dosing. The STEMI dosing goes all the way up to a maximum of 50 milligrams. Stroke maxes out at 25 milligrams. It's 0.25 milligrams per kilogram up to a maximum of 100 kilograms or 25 milligrams. So we really want to make sure that you're familiar with that and have read it thoroughly before the 12th so that you feel comfortable ordering that when you need to. It's easier to administer. It's just a a single bolus with no infusion. And then, there have been studies that have shown that this is as or more effective than Alteplase with a slight reduction in frequency of bleeds, not enough to necessarily change our discussion with the patient. Typically we provide information of up to a 6% chance of intracranial bleed. Those discussions will continue to stay the same with this medication. Any questions on this? The order has not appeared in the emergency medicine ischemic stroke thrombolytic order set yet, but presumably it will on Go Live, which will be the 12th. If it doesn't, then obviously we'll have some communication about that. Our door to needle times are slowly creeping up a little bit. That 1 hour and 52 minutes, that was an N of 1 in August, so that throws us off a little bit. But our median door to needle time is 45 minutes, and our average is 52 minutes. And unless we bring it down in the next couple months, we're going to be at risk of not meeting for the first time in 7 years our Elite Gold Plus get with the guidelines. We're the only site in Michigan to have gotten this for 6 years in a row. So we want to get it for our 7th year. So be cautious of that. The nursing staff is getting some reminders as well. They are empowered to activate the stroke page and transport to CT based on a new BFAST positive within 24 hours without notifying the provider. Obviously, they notify the provider, but they are empowered to activate the team and transport to BFAST upon their initial assessment, whether it be in triage or EMS arrival. So communication to improve time is the key. Make sure that your nurse knows that you're considering giving TPA so that they can be prepared to do that in a timely fashion. Obviously, the ED pharmacist is helpful, but they're not there all the time. So, there are times when it's actually getting mixed by CCTRN or nurse. Okay. This is just a quick reminder, there is also a fibrinolytic panel. So if you type in T in case, this is what will come up. Just be very aware that right now until the 12th, T in case is on this panel, but it is dosing per the STEMI dosing. So don't order the STEMI dosing, order the ischemic stroke dosing. It's just a quick reminder that we are starting this. Any questions on stroke or T in case? Okay. So quick reminder that we are starting this AIMS trial. Some of us have already had interviews for this for the pre-trial interview. I'm going to skip over this, more to come later. It hasn't been started yet. Patient experience, we continue to have a strong focus on patient experience in the emergency department from the hospital and the system. And we, as you know, we have switched from Press Ganey to Qualtrics. Our Qualtrics likelihood to recommend numbers are a little bit lower than our Press Ganey. I think there is some kind of apples to oranges comparisons because the survey, although many of the questions are the same, it's coming in a different manner. It's coming faster. It's coming by email, and that may change some of the demographics of who's responding. So combined Southwest ED 60% right now. This is one of the tools that they have for us. This is a key drivers. And I know this is really small, but I'm going to try to translate it for you because I think that this is an important tool to help us as a team, an entire team, including the nursing staff and the ancillary care as well, to focus on what's important when we're, because we can't focus on everything. We gotta, do just a couple simple things. And so this horizontal and vertical line, the horizontal line, basically the stuff below that line is less important, and the stuff above the line is more important, meaning the higher up on the vertical axis, the more that question is affecting our likelihood to recommend. And then the horizontal axis is good or bad. Are we getting good responses or bad responses for the question? So we want to have a lot of stuff in that top right corner because that's a key driver, and it's also good. But I've highlighted some of the things here that we as providers are doing really well, and some of the things that deserve more effort. So the things that we're doing really well are provider responds to concerns and complaints, provider treats patient with courtesy and respect, and also provider explains things in ways the patient can understand. Those are all things that we are doing quite well at. Areas that we are a little bit left of the vertical line, opportunities for improvement, but are also highly correlated with likelihood to recommend, are provider concern for comfort and provider listens carefully. Perhaps the most important one that is, pretty far to the left and also most important is staff work together as a team. So that teamwork one is a big driver, and it's a big opportunity for us. And then the whole reason this is so small is because our informed about delays is so horrible that it's like on a practically different scale. It's like the 12th percentile. It is so far to the left. Fortunately, it's also below the horizontal line, so it's not as key a driver, but it is just by far our worst metric. So a little bit about that. Why is it low and also to the left? So on the left here, you can see 17% experienced delays during our visit. So that's actually not that many. Only 17% experienced delays. But as you look just to the right of that circular, the people who were informed about delays, who had delays, were not informed well at all. So either not at all or a little. I mean, we do horrible with that. But fortunately, not everyone has delays. So you can see that reflected on the right here, that 52% rate us very good at waiting time. So these are the people that didn't wait. But the ones that did wait are not getting informed about delays. So I think that helps us to target this, that, we really do need to inform people about delays that are having delays. We don't need to do it for everyone, but it helps us target that. And then we're doing pretty good with the Big Finish. We are at 89% either very clear or extremely clear. We go by top box, so we'd like to move those very clears to extremely clear in terms of the aftercare instructions that the patients are receiving. But in general, we do very good with this. So what are our action items? Simple, easy to do stuff. Let's try to pick out a couple simple things. Our opportunities for improvement for providers are listening carefully to you and caring for your comfort. And two additional opportunities are working together as a team and informed about delays. So here is the ask. Simple things that basically we already know, but if we could bring these to the forefront. We know that when you sit down, there's a perception that you are listening more carefully and that you're spending more time with the patient. So, when you go in and you're taking your history, just sit down. This also is a push that the inpatient team is doing. They're doing a big sit down push to try to improve this metric on them as well. So we're kind of coordinating that. So remember to sit down, simple. And then concern for your comfort. This doesn't necessarily mean you need to give them a lot of, opioids and these kinds of things. Remember, the comfort can be their pain from their medical condition, but it also can be, is their call light accessible? Do they have the TV on? Is their privacy addressed with a curtain? So simply saying the words, and Press Ganey has taught us this, that if you say the words that are in the survey, they will remember it better. So if you say, I'm concerned about your comfort, or what can I do to make you more comfortable, or are you comfortable? If you use those words, it will improve their perception of how you feel about their comfort. So even if it's, can I adjust the head of your bed? I'm closing this curtain for your privacy. Hey, I want to wait to give you this medicine until after the scan because of X, Y, or Z, or we're giving you some pain medicines. I want to make sure that you're comfortable. Make sure you let the nurse know how you're doing. And also, the goal of our treatment is not to remove your pain completely, but to make you comfortable. Sometimes you need to describe, that, we're not providing general anesthesia here. So using those words is quick and simple, and it should help working together as a team. This is a tough one. It's hard to judge what the patient feels is a lack of teamwork, but I think it's fairly obvious that if the nurse is telling them one thing and the doctor is telling them something else, there's a perception that they're not working as a team. So one thing we can do is to make sure that our plan for the patient is communicated appropriately with the nursing staff. So, if you're planning on doing a repeat troponin, make sure the nurse knows, hey, I'm planning on ordering a repeat troponin, or we're waiting for this, or such, so that you're both providing that same feedback to the patient. And then finally, informed about delays is just do it. We just haven't been doing it. Somebody is there longer than you expected them to be there. Hopefully, we're telling patients during our initial assessment how long we think their stay will be. And if it's longer, make sure you're going to the bedside and tell them what's going on and what the updated time will be. Simple stuff, but I think it hopefully will nudge the needle a little bit and provide some better experience for patients because of it.
Dan, I have a question about this. As far as delays, do we have any sense of when these delays are occurring? I think we presume, it must be when they're in their rooms and they're feeling it's taking too long, but I wonder if that might not be the case. Like, I imagine they perceive waiting room as a delay, and that must feel like a death trap to them. And are we doing anything to have a rounder out there or address the wait concern in the waiting room?
I've had a lot of discussions about that, and Julia, I think you're right. It's both. It's got to be both. I mean, we don't know, because the question doesn't ask, did you have a wait in the waiting room? And then a separate question, did you have a wait after you were placed in a room? So we don't know. I'm presenting this to the providers because we're not out there in the waiting room, but we've tried to do some sort of rounding in the waiting room for a long time. We've talked about things like a hospitality rounder. The problem is, most of the time we don't have a wait in the waiting room. And when we do, we don't have enough staff to be doing extra rounding, because, it's 5 o'clock on a Tuesday, and, all the extra staff is placing patients and doing those things. So it's challenging, because when we need that extra rounding staff out there, they're busy opening up hallway beds and doing those kinds of things. So we are continuing to have discussion, amongst with the nurse leadership team, The expectation is to be rounding on all of those patients. It's always been, you know, at least every hour for patients that have waited longer than an hour. I personally advocate for, you know, at least every half an hour. But it's something that we have to coordinate with what we have available in terms of our resources.
My last comment was with regard to working as a team. I don't know if you remember, like a couple of years ago, I surveyed all the board and then I surveyed several nursing administrators about what was the goal of care in the ED. And they had their goal and we had our goal. It was very apparent that we are not on the same team. So my other thought is that we need to address that. The patients feel like we're not on the same team because we're not playing the same game. And that's all the thoughts I have.
Very, very true. And I think some of those, some of what you're talking about there may have been difficult for the patient to perceive because some of the goals were kind of work goals rather than patient care goals, being somewhat different. But it's, you know, it's hard to change the bar on teamwork because it's hard to imagine what it means to a patient. I'm open to additional feedback on that one. It's our most important one, and it's hard to come up with a simple, easy plan to fix it, but gotta start somewhere, right? All right. And just a reminder, keep doing what you guys are doing well already. And, you know, I think we've had good improvement with patient experience. I certainly want to raise that up and highlight that. Courtesy and respect amongst providers is great. Responding to concerns and complaints and explaining things with the big finish, great job. Keep up the good work on those, and those things are bringing up our numbers. So good job. All right. Done in less than an hour. This is our opportunity for open forum, any sort of discussion or points, anything about what we've presented today. Other things you may have seen in the provider updates that you've been getting approximately weekly, or anything else to bring up. Now is the opportunity. Going once. All right. Well, have a great Wednesday, and we'll chat later. If you guys have any other concerns or anything, obviously, I'm always available.